Thank you for joining Cancer Support Community Atlanta for new treatments for localized and advanced prostate cancer, facilitated by Dr. Vahan Kassabian with Advanced Urology and moderated by Dr. Crain Garrot with Georgia Cancer Specialists. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to new treatments for localized and advanced prostate cancer. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, where you can see all the free oncology support services offered virtually, which range from virtual support groups to monthly oncology nutrition seminars. If you miss a live event, you can find a recording of it on our website as well. Again, that's cscatlanta.org. I also want to highlight the virtual prostate cancer support group, which meets monthly and is facilitated by a licensed mental health professional. As I said earlier, everyone will remain muted. Throughout the presentation, we invite you to enter questions into the program chat box, which will be addressed during the Q&A at the end of the program, time permitting. I want to welcome today's program moderator, Dr. Crain Garrot. Dr. Garrot is a board-certified medical oncologist with Georgia Cancer Specialists. Dr. Garrot received his medical degree from Louisiana State University School of Medicine, New Orleans, Louisiana. He completed his fellowship with Beth Israel Deaconess Medical Center, Harvard Medical School in Boston, Massachusetts. Dr. Garrot has a special interest in general oncology and hematology with an emphasis in gastrointestinal cancer, genitourinary cancer, and hematologic malignancies. And with that, welcome Dr. Garrot, and I will go ahead and pass it off to you to introduce today's presenter.
Excellent. Well, thank you, Katie, for that introduction. And I want to welcome all of the attendees. It's actually great that we have this virtual platform, because in years past, we've had meetings like this for the community to hear about medical topics, and they're usually in person. And so you usually get 20, 30, 40 people to come, and now we have, I think, over 200 registered attendees, and we hope that all those folks come and join our meeting virtually. And we've actually had people from all locations around the state. We've actually had some people come from North Carolina and Florida. So it's great that we can communicate these medical topics to you all in the community and talk about these things that are worthwhile for you. So I want to, if you could advance the slide one, I wanted to give a little shout out and kudos to the Cancer Support Community of Atlanta. Cancer Support Community is a national organization, but Atlanta's chapter is actually very, very strong. And they offer a lot of support for patients who are going through cancer, going through cancer treatment and survivorship. They have a lot of programs. So I would invite you to go to cscatlanta.org to see what programs they can provide for you, whether it's educational programs like this or other support things like the nutritional seminars and stress reduction classes. All those things are very beneficial for patients. And we, as the practitioners, affiliated with CSC and with Northside Cancer Institute, have benefited by having our patients helped. So I want you to try to use that resource if you can. And if you could advance the slide one more. I also want to say thanks to Northside Hospital Cancer Institute. That's sort of the parent organization under which we work. And they have done a great deal of work for cancer screenings and health screenings. They have clinical trials. We actually participate in a number of genitourinary clinical trials. And you can look that up online and stuff like that. And they do a lot of genetic counseling. Northside Hospital Cancer Institute is also one of the main supporters of the CSC. And so they go hand in hand, which is why it's sort of joint sponsored by this program is joint sponsored by both organizations. So, kudos to the hospital system for helping us do this to communicate all these topics for you. Without any further delay, I was going to introduce our featured speaker, if I can get it out right, Dr. Vahan Kassabian, who is a board-certified urologist. He earned his medical degree and did urologic training at the University of Montreal in Quebec. He completed a fellowship in urologic oncology at Baylor College of Medicine in Houston before joining faculty here at Emory School of Medicine. He was also the chief of urology at VA Center and has been in the Atlanta community for nearly 30 years. He specializes in complex urological cases and provides novel therapies for advanced cancer. He is a nationally recognized surgeon and a pioneer in HIFU, the high intensity focused ultrasound, which we'll talk about today. And he practices with Advanced Urology and is the current director of the Atlanta Prostate Cancer Center and Advanced Therapeutics. Also, on a personal note, I've worked with Dr. Kassabian for many years for genitourinary cancers, and I do consider him one of the top 1 or 2 surgeons in Atlanta for urologic cases. And I tend to send him all the hard stuff, and he takes it on without any issues. So it's really great that he's in our community. So Dr. Kassabian, I'll turn over the floor to you and let you give you the presentation.
Thank you, Dr. Garrot. It was a nice presentation. It's an honor and privilege to be here with you guys. And I'm going to talk about sort of 2 spectrums in prostate cancer. You know, when men get diagnosed with prostate cancer, it's really a journey. And for most of them, the journey ends very well. And, you know, we do a good job of curing most patients. But some of them go on to recur and eventually need more complex advanced prostate cancer therapies. So my 2 topics for today, the first one really is for the early stage prostate cancer, and then the last half is sort of for the advanced prostate cancer. And I have a passion for both these extremes, and I like to take patients through what I call the journey of prostate cancer. So first off, I'm going to talk to you about high intensity focused ultrasound, or HIFU. Approximately 1 in 7 men in the United States will be diagnosed at some point in their lifetime with prostate cancer. And prostate cancer can be very scary and confusing. And it's very different how men react when they get diagnosed with prostate cancer, say when a woman gets diagnosed with breast cancer. Both diseases are very similar. They both occur in what we call secondary sex organs, the prostate and breast. They're both hormonally dependent, testosterone, estrogen. The numbers and demographics are very similar, and yet when a woman gets diagnosed with breast cancer, she calls all her friends, they go to lunch, they talk about it and talk about what to do. When men get prostate cancer, they sort of run the other way. We're sort of creatures of that, and we don't like to talk about it, we run to the closet, but I urge all men to seek better information about all the different treatment options, to talk to their friends and family, to talk to multiple physicians before they make up a decision of what treatment they think is best for them. The United States, as I said, 1 in 7 men get prostate cancer. That's about 160,000 new cases diagnosed in the US. But unfortunately, it's still a very important contributor to cancer-caused death in the United States. It's about number 2 right now. And we used to have more prostate cancer cases on an annual basis, close to 240,000. So the history of that goes to the PSA. When PSA came into fruition in the late 80s, early 90s, we had a huge rise in the amount of prostate cancer that we were finding. And then eventually, we realized that we were probably over-treating some men who probably didn't need to be treated. So how did we get to this point? Well, the US Preventive Task Force recommended PSA as a very poor test back in 2012, and they give it a D rating, which is one of their lowest ratings. And what happened was a lot of family physicians, internists stopped doing PSAs. And unfortunately, what we found is that now there's a rise in the number of patients that when they get diagnosed with prostate cancer, it's already too late. The cat's out of the bag, they have metastatic disease, and unfortunately, we can't cure most of these patients. We can certainly help them, but the way to cure prostate cancer is to find it as early as possible. So we encourage men to still get screenings, to still get PSA, to get rectal exams. What has changed over the last several years is active surveillance has come into the foreground. So most prostate cancer patients who are diagnosed don't die of their disease. Obviously, we want to do the right thing when we get them diagnosed in their early stages, and active surveillance certainly is an option for some men, but it's not an option for every man. And back in 2016, about 4 years ago, the New England Journal of Medicine published 10-year outcomes of men having different treatments, and they found that nearly 20% of active surveillance patients get treated within their first 2 years, and more than 50% received some treatment within that 10-year span. So if you start off on active surveillance, doesn't mean you're going to end up on active surveillance. It just means that we need to keep a close eye on you, and that we don't think your cancer is really that aggressive to warrant immediate treatment. Of men that went into the active surveillance arm, 6.3% ended up having cancer that had spread to their body. So what has changed? How can we better predict which patients are good patients for active surveillance? Well, PSA is still very important, so we need to do a better job at screening these patients. But we also have tools now to help us differentiate the bad actors from the good actors. We have MRI that's available. We have certain genomic testing that's also available. Some have also recommended, instead of using a PSA cutoff of 4, we should maybe lower it to 1.5 to catch some cancers that are more aggressive even earlier. But there's also, there's also less aggressive options that allow for focal therapy. So as you know, we have active surveillance on one hand, and then we have traditional treatments like radical prostatectomy, which is surgery, or radiation therapy in different forms. But we really don't have anything in the middle up until a few years ago. So most patients really were given the option of active surveillance or more aggressive treatment with surgery or radiation. Well, this is where a minimally invasive treatment like HIFU, or high intensity focused ultrasound, comes into play. It's an ablative therapy, just like cryo, just like radiation. However, it's not using radiation to kill the prostate, it's using heat. If we look at the potential benefits of HIFU, there's reduced side effects. It's an outpatient procedure. The procedure can last as little as an hour or as long as 4 hours. It's a quick recovery. There is a catheter that's left in place, usually for about a week, and the ultrasound waves create heat. And as I said, it's not a form of radiation, but it is a form of ablative therapy. We're not actually removing the prostate, and there's little blood loss, if any, for most patients. So high intensity focused ultrasound uses energy, ultrasound energy, to direct it to pinpoint to create heat, and that heat destroys the tissue. The analogy I like to give is, if you have a magnifying glass, if you remember as a child, you could put it to sunlight, you could burn a leaf. If you were too far, nothing would happen. If you were too close, nothing would happen. You could actually put your hand in front of the magnifying glass as it's burning the leaf, and nothing would happen to the hand. So these are the physical properties of generating ultrasound waves, and we do it through a probe in the rectum. That the ultrasound waves travel from the probe through the rectum, and we pinpoint it to a specific spot on the prostate or inside the prostate. So this is a very novel way to treat as much or as little of the prostate as we want on a focal point. And that focal point is only 3 millimeters wide and about 12 millimeters long. So obviously, the bigger the prostate or the larger area that we want to treat, the more time consuming it is. Here are some picture diagrams of how we can treat prostate cancer with HIFU. You can see here, these circled areas are the neurovascular bundles that are responsible for the erections. But then we can treat just a little area of the prostate where the cancer may be. We can treat half the prostate, or hemigland ablation, and we can certainly treat the entire prostate as well. So as I said, it takes a couple hours to do these. It's under general anesthetic. It's an outpatient procedure, and most patients return to normal activities very quickly. They're eating a regular meal at home, and we don't give any narcotics for pain control. We just give anti-inflammatories. So if you think about prostate cancer and the analogy I gave to breast cancer earlier, in breast cancer, we went away from radical mastectomy, removing the whole breast, to lumpectomy. And we're sort of going in that direction with prostate cancer. Most prostate cancer is not lethal. Most prostate cancer can be managed with focal therapy. It's choosing the right patient or the right candidate that's a good patient for focal therapy. So why focal therapy? Well, the main reason is to minimize the side effect profile. Unfortunately, where the prostate sits, it sits in the pelvis, and it's right below the bladder, right above the urethra. The rectum is right behind it. The nerves responsible for erections are on either side. So there are urinary issues and sexual issues that come into play whenever we treat a patient with localized prostate cancer. And that has been the issue all along. Look, if the prostate was in the middle of the chest, like a breast is, we wouldn't be having these functional issues. But because of where it sits, we want to minimize the side effect profile. So let's look at some of the data that's been published on HIFU. And I have some here on the right from 2012, and I have here on the left from 2015. And most of these trials that we have until recently have all been done outside the United States, mostly in Europe and Japan. So if we look at on the left-hand side here, which was 219 patients, negative biopsy rate was 87%. Very few patients had urinary leakage. There were no serious events such as a rectal fistula. That's pretty much a hole in the rectum, which is obviously devastating. The bladder neck contracture was also low, but the stricture rate or the scar tissue that can form the urethra was about 18%, which can be fixed with a minor surgical outpatient procedure. Let's look on the right-hand side now, where we did some focal therapy. This was a small number, it was only 41 patients, but again, this goes back to 2012. And absence of clinically significant disease was as high as 92%, and the retained sexual function, 89%, 100% continence, no urethral fistulas or strictures. So that's where focal therapy comes into play, right? HIFU in of itself, if we do total gland, we're already reducing the side effect profile and getting a good cancer control, as you can see here in the numbers. And these were obviously not head-to-head trials with surgery or radiation or HIFU, but these were different studies comparing different results. So it's a little bit like comparing apples to oranges, but we can still make some sense out of it. So you can tell that the retained sexual function rate with full gland or focal HIFU is much higher than radiation or surgery, and it has a high maintenance of urinary function as well. The more recent data, and this was published in the European Urology in 2018. This was a French cohort, but multi-institutional. That means many centers around Europe participated. It was a 5-year study following focal therapy only. 625 patients, 85% maintained their erectile function, 98% maintained their urinary continence. The metastases-free or cancer not spreading, cancer-specific or overall survival, in other words, the patient still being alive without cancer, was extremely high, 98, 100%, and 99% respectively. So the results seem to maintain that, at least in the short-term 5-year data, the results were equivalent to surgery. So it also incorporates that it is possible to treat these patients with focal therapy for the right patients rather than with total gland ablation. Here is another trial. This was a UK, also a high number of over 600 patients, again, showing very similar results with the focal HIFU. Again, excellent cancer control, excellent preservation of both urinary and sexual side effects. So really, it's the sexual side effects, in my opinion, that make HIFU stand apart from the rest of the treatments that we have available. The British Journal of Urology also published an article last year, again, with medium-term oncological control or cancer control in over 1,000 patients. Again, this was the largest study, all focal HIFU patients. Majority of patients had excellent cancer control. 26% of the patients had to have a second treatment, whether it's a repeat HIFU, which can be done. You can do HIFU again, or some other modalities, such as cryotherapy. You can still do radiation in patients after HIFU, and you can still do surgery. 25% of the patients had a biopsy failure, but we were unable to determine if this was inside the area that was treated or perhaps outside. So anybody who has focal therapy, we still need to keep a close eye on these patients, make sure they don't have a recurrence of the cancer outside of the area that was treated or even inside. More recently, in fact, earlier this month, in the Journal of Urology, this is obviously an American journal, we had, again, 4-year retrospective analysis of hemi-gland ablation. In other words, they treated half the prostate. So this is sort of like focal therapy, but more, but obviously less than treating the entire prostate. So hemi-ablation, again, 100 consecutive patients were treated with low to high risk clinically significant non-metastatic prostate cancer, followed for at least 2 years, and this was going back for 4-year data. 73% of patients did not experience treatment failure, and 100% of them had urinary continence, so no urinary issues there. So this was the largest focal or hemi ablation studies done in the United States, and again, just published this month in the Journal of Urology. Before I transition to the next half of the presentation, I want you to keep your questions on this part till the end. That way I can answer all the questions depending on what they are. So now here's my second love, which is advanced prostate cancer. As some of you may know, I've spent my career early on here in Atlanta doing a lot of radical prostatectomies. I was not one to adopt the robot. I'm still do all my surgeries with an open technique. But even when I was doing all these open prostatectomies, I said, you know, there's got to be a better way to screen those patients and do a better job of reducing the side effects. That's why I started to do HIFU, and I've been doing HIFU for 14, almost 15 years now. Being trained in Canada, I was licensed up there, so I would take my American patients, fly to Canada, treat them, and then follow them back here in Atlanta. But because the FDA approved it several years ago, I do it here now. But my second love, as I said, is finding therapies and being on the cutting edge of patients who unfortunately end up with advanced prostate cancer. As I said earlier, prostate cancer is very hormonally dependent. Testosterone is a driving engine. It's like adding fuel to the fire. If we go back to the 18th century, you can see that castration was recommended in patients who had obviously advanced prostate cancer. But if you look forward, in 1940, so this is 80 years ago, that and the Nobel Prize was awarded to Huggins for discovering that testosterone was a driving force in prostate cancer, and that surgical castration or removing a man's testicles would decrease their testosterone and help treat prostate cancer. Fast forward now from 1940 to 1980. So it took us 40 years to go from surgical castration to medical castration, which is basically a shot every month or 3 months that we give our patients that reduces the testosterone production. So since then, we've had some novel therapies, but all these therapies, at least on this slide, are all related somehow to the androgen synthesis pathway or blocking the effect of testosterone on the end organ, i.e. the prostate cancer cell. So in the mid-90s, we had what we called first-generation anti-androgens, such as bicalutamide, which was a very common one, flutamide and ilutamide. And then in 2003, we had another shot, but it was really an antagonist. It's a little bit different than what we had in the early 80s, which were agonists. But then we also began to have orals or pills, second-generation anti-androgens that affect either the androgen synthesis, to just abiraterone acetate, that blocks the production of testosterone wherever that may be. And then also we had novel anti-androgens or second or third generation anti-androgens, such as enzalutamide, apalutamide, and more recently darolutamide. All these are similar mechanism of action, and they block the effect of testosterone on the end organ. The future, I think, we're going to have more and more targeted therapies. We're going to have more vaccines. We're going to have better biomarkers, and also we're going to have better genetic research, and I'll talk to you about that early on. So let's just talk about some definitions for some people who are not familiar with some of the definitions. So ADT, androgen deprivation therapy. In other words, we give patients hormones or shots that lower testosterone. That's the foundation of therapy for patients with advanced prostate cancer. We want to lower testosterone as low as possible. We know that the side effects are horrible. It'll make you feel like a woman going through menopause, but we call that andropause. Hot flashes, weight gain, cardiovascular issues, bone loss, osteoporosis, sexual effects. So all these obviously are horrible because it really speeds up the aging process. Metastatic disease or metastases means that the cancer has spread to other organs, and typically in prostate cancer, it's lymph nodes, bone, viscera, which is any organ such as lung, liver. Non-metastatic means it has not spread. CSPC stands for castrate-sensitive prostate cancer. In other words, the patient or cancer has never been treated with ADT, or they are on ADT and they're still responding very well and there's no progression. CRPC, castration-resistant prostate cancer, which means that the cancer is growing, the PSA is rising, the cancer is growing, despite ADT that's on board and ongoing. HRR, homologous recombinant repair, and these are in patients who have gene mutations. And this is very new because now there are 2 drugs that got FDA approved earlier this year around May that are specific for patients who have these HRR mutations. So MCSPC stands for metastatic castration-sensitive prostate cancer, still responding to hormones or not receiving hormones. Non-metastatic CRPC, castration-resistant. In other words, the PSA is rising, but we image, there's no metastases, but we know the hormones are no longer effective. And then metastatic castration-resistant prostate cancer, the cancer is spread to another lymph node or bone or organ despite ADT and castrate levels of testosterone. So here's what I call the roller coaster graph or slide of prostate cancer. And as I said earlier, prostate cancer is a journey. For most patients, it stops right here where we've treated them with therapy, surgery, or whatever, and we've cured them, and there's no progression. But unfortunately, some patients have biochemical failure, their PSA begins to rise. We can treat that with ADT, which is the foundation of therapy down here. And then we have failures despite ADT. So anything to the right of here is castration resistant. Anything to the left here is castration sensitive. And I know this looks confusing. There's a lot of medications here. There's abiraterone, enzalutamide, which are 2 pills, CYP-T, which is an immunotherapy, apalutamide, darolutamide, which are also androgen receptor inhibitors. There's chemotherapy here at the beginning, docetaxel, there's chemotherapy again, and there's another second-line chemo, cabazitaxel. There's radium-223, which is radionucleotide. I know it appears confusing, and it would take you a long time to understand this, but this is the simplest way that we as physicians can explain where all these therapies fit into the prostate cancer timeline. So let's talk now first about how we can treat metastatic castration-resistant prostate cancer. So cancer that is continuing to progress, has spread to another part of the body, and hormones are no longer working. And this is where we've made the greatest stride since 2010. So over the last 10 years, all these therapies have come into play. And remember, for 80 years, we only had hormone therapy in different forms. But now, over the last 10 years, we have this plethora of therapies, and they all fit into a specific place in the journey. Immunotherapy, Sipuleucel-T, which was a way for the patient's immune system, sort of like a vaccine, to be ramped up. You get 3 autologous transfusions of the patient's own blood cells that have been trained to fight prostate cancer, and they're given back to the patient. That was approved in 2010. Androgen synthesis inhibitors, such as abiraterone, cut the production of testosterone wherever that may be. And this is also pills. This was also approved in 2012, I believe. Androgen receptor inhibitors, there's 3 of them currently on the market. Enzalutamide, which is Xtandi, apalutamide, which is Erleada, darolutamide, which is Nubeqa, and they each have a specific place in the journey, but they're all biochemically quite similar in the way they treat prostate cancer by blocking the effect of testosterone wherever that may be. So they don't lower testosterone levels in the blood, they just stop the effect on the cell. Radionucleotides, radium-223, also known as Xofigo, came into play a few years ago, FDA approved, and this was the first radionucleotide that offered a survival advantage. It just wasn't only for bone pain and make patients feel better, there was actually a survival advantage. And of course, we have chemotherapy, docetaxel, Taxotere, which was approved in 2004, cabazitaxel, which was approved probably, I think, about 8 years ago. Again, these are chemotherapy agents that are approved in certain spaces in the journey of prostate cancer. PARP inhibitors. This is the newest class of medications, and there's 2 of them, rucaparib, which is Rubraca, and olaparib and Lynparza, which are actually also indicated in other cancers, not just prostate, but they're indicated for patients who have specific gene mutations, such as BRCA1 or 2. Again, I'm going to compare breast cancer and prostate. We now know that the BRCA gene is important in certain patients with prostate cancer, just like it's important in certain patients with breast cancer. So again, a lot of similarities. MSI, which is of specific gene mutation, pembrolizumab or Keytruda is approved in this space. MSI stands for microsatellite instability. Again, it's not specific for prostate cancer. You can see this gene mutation in other cancers. In fact, pembrolizumab was approved for MSI instability for different cancers. And I think it was the first therapy approved in multiple cancers based on a specific mechanism of action. So again, this is going to look confusing to you, and I have a timeline here from 2004 all the way to the present and beyond of different therapies that have been approved in prostate cancer, and they're specifically for the ones that I just discussed earlier. But let's go through this. So here at the bottom, you have metastatic castration or hormone-sensitive prostate cancer, or again, responding to ADT, or the cancer has not been treated with ADT. So we had initially Taxotere, then we got Zytiga, and now we have Erleada and Xtandi. All are indicated for patients who have this disease state, which is metastatic prostate cancer that has spread, but also still responding to ADT. Each one has different side effects. All these are orals, pills, except for the Taxotere. Let's move on to the next bucket. We have non-metastatic castration-resistant prostate cancer. And this is sort of a timeline. This is how most patients present. But now we go to the castration-resistant space where the hormones are still given, but the PSA is rising, there's progression, but we can't find any evidence of the cancer spread on imaging, on bone scan or CAT scan. We have 3 oral drugs, all similar mechanism of actions, that they stop the end organ effect of testosterone on the prostate cancer cell. You have Xtandi, Erleada, and Nubeqa. And then the next bucket is metastatic castration resistant. In other words, the cancer has spread, the hormones are no longer effective. And this is where most of these drugs got approved first, back earlier on in 2010, 2012. So you had Provenge, which is the immunotherapy. This one probably has the least side effects because you feel like you have the flu. It's only there to boost your immune system, but it's only given one time. It's not something you take continuously. You take it 3 infusions, 2 weeks apart, and then you're done. The Xtandi, again, is an oral pill to be taken every day. And then you have Zytiga, which is another pill, as I mentioned earlier, angiotensin synthesis inhibitor. Taxotere is a chemotherapy, usually given for about 6 cycles. Then you have Xofigo, which is the radionucleotide that's also an infusion once a month times 6. Again, it was proven not only to affect, improve survival, but it really is for patients who have cancer in the bone, because that's the way it works. The mechanism of action is that's where it attacks. It attacks cancer cells that are only in the bone. And then the last bucket here, you have metastatic castration resistant with this HRR mutation. And I'll talk to you about that shortly, but Lynparza and Rubraca are indicated for patients who have this gene mutation. Examples of common ones are the BRCA mutations, like I said, similar to breast, and now we know they're available and can also cause aggressive disease in men with prostate cancer. So you have to have this gene mutation to be eligible to receive any of these 2 medications. So I promised that I would talk about some of the new data that has appeared in advanced prostate cancer. I just talked to you about those 2 oral therapies that got approved in May of this year. But in December of last year, we published a paper in Cancer on immunotherapy. And I was privileged to be one of the authors in this trial. And this was based on the CIFT, or the immunotherapy in castration-resistant prostate cancer. When it was approved in 2010, the FDA mandated a registry trial. That means patients who were given Provenge or Sipuleucel T commercially, we followed these patients to see what the outcomes would be, to see if there were any signals, any side effects that may have been missed, such as cardiovascular events. So that was specifically mandated by the FDA. So this data was published in December of last year in Cancer, and what we do know is that for a specific cohort of men, especially African American men who did receive Sipuleucel-T or this immune therapy, for reasons that we don't yet understand, African American men responded better to immunotherapy than Caucasian men. Again, we don't know why. And this was despite these African American men having higher PSAs at entry and receiving Provenge. I think their PSAs were in the 33 range rather than in the teens in the Caucasian men. So we don't understand why these men responded better to immunotherapy. Is it something in their blood? Is it genetic? We don't quite know the answer, but this was a rather novel, important finding that we don't know exactly why, but African American men seem to respond better to CIP-T, to immunotherapy, than Caucasian men. So now let's talk about genetic mutations in prostate cancer. So when the prostate cancer has already advanced to other parts of the body, more than 1 in 4 men harbor a gene mutation. And this is a high number, right? 10 to 12% of these are germline mutations. In other words, these are genetic mutations that have been handed down by either the father or the mother to the patient, and they harbor this gene mutation. It's in every cell and in every cancer cell. So these patients who harbor germline or genetic mutations handed down, they're at higher risk of cancer, number 1, more aggressive cancer, number 2, and number 3, cancer at an earlier age. The rest of these patients, so remember this is 1 in 4, so where do the other 15% or so come from? Where they're somatic mutations. In other words, the prostate cancer cell has gotten so aggressive that at some point in its development, in its growth, it has developed this gene mutation that is not something that is present in a normal cell in the patient. So this is important for us now because now we have treatments that are specific for these mutations. BRCA1 and 2 are the more common ones. ATM is another common one. And then you have these other ones here listed down below, such as CHEK2 and others that are much less common, but also indicated in these HR mutations where some of these oral therapies would be indicated. So now we have treatments we didn't have before May of 20 this year. We have treatments specifically for patients who have genetic mutations. And the NCCN, which is the National Body Cancer Network, that tells us how to, or give us recommendations on testing and treatments for different cancers, but specifically for prostate, they recommend germline testing for any patient whose prostate cancer has spread to other parts of the body, or those that are high risk or very high risk regionally in and around the prostate. Ashkenazi Jewish ancestry, we know they have a higher rate of BRCA mutations. Family history of high risk germline mutations. So if there's a family history of other cancers, specifically prostate, breast, pancreatic, and others, that's a reason to test for germline testing. And the germline testing can be easily done either through a blood test or a swab in the mouth. We call that a buccal swab. We also can test the tumor. In other words, that's somatic tumor testing. So typically, if we're looking at prostate tissue or we do a biopsy of a lesion, say a lymph node or other area where we can procure some cells to get it analyzed, then we can look for these mutations that weren't present in the germline testing. There's also now testing that can be done in the blood, looking at both germline and somatic testing. So rather than getting tissue to analyze, we can do this for the blood, and they look at circulating tumor cells and try and pick up DNA. This is how precise some of this testing has done. And patients who have advanced prostate cancer, I think, should all have testing to see if they're candidates. So what's in the future? Let's talk about the future as I conclude with my last slide, and I'll be glad to take some questions after. So if you look at this, this is the way prostate cancer can be targeted. So we know that we have androgen receptor inhibitors here at the top. We already have products or therapies in that space. We have PARP inhibitors. We have 2 of them targeting these BRCA1 and 2 mutations and others. We also have, for other disease states, we have checkpoint inhibitors. And we are trying to, the research currently ongoing now in 2020 and beyond is looking and affecting any of these pathways that can promote cancer growth and attacking different mechanisms that promote cancer cell growth. So it won't be unusual that in the future, we'll have more and more targeted therapies, more and more specific or precision medicine, perhaps a single agent, 1 drug, or more than likely multiple drugs, at least 2 or perhaps 3 drugs, affecting the cancer growth with different mechanisms of actions in different pathways. So I want to conclude that the future is very bright for prostate cancer. We went for many decades with only androgen deprivation therapy. Then we had chemo in 2004, and now we have all these therapies that have come into fruition only in the last 10 years, and the future is very promising. I want to thank everybody. I wish we were virtual and I could see you and talk to you in person, but I think virtual is the next best thing. And to Dr. Garrot's point, we can certainly have an increased, wider net to attract patients from across the country, and more patients can attend. I want to thank everybody for attending today.
Dr. Kassabian, thank you very much for that wonderful review.
Jessica, please call.
Office phone of that wonderful review of advanced cancer and HIFU. We have a number of questions, and I would want to invite the audience to continue to offer questions. We have probably 10, 15 minutes, I guess, unless Katie tells us we have to stop earlier, or we could even keep going if there's other questions that we would want to address. So I'll start off with a number of the questions that came in from the audience, and it is, the first question is, how effective is HIFU for men with isolated local recurrence for prostate cancer after they have been treated with radiation?
So we call this salvage therapy. Salvage therapy, in other words, the first therapy has failed, and salvage therapy after radiation can be treated in several different ways. Surgery is one option to remove the prostate. That has a lot of side effects, unfortunately, after radiation. Cryotherapy and HIFU are probably the 2 best approaches for radio recurrent prostate cancer, which is what this question is specifically. Now, bear in mind that a salvage therapy typically has more side effects than the original therapy. So, for example, if you remove a prostate surgically after radiation, there's a high chance of having either erectile dysfunction or urinary issues. So the second therapy always has a higher side effect profile. The easiest would probably be HIFU and then HIFU again. The worst is probably radiation followed by surgery. But yes, salvage therapy would be an option for this patient, either cryotherapy, surgery, or HIFU.
Thank you. There's another question. There's actually 2 questions, but they're kind of the same, so I'm going to combine them. And it is, what is the clinical presentation that leads you to choose focal therapy, and how do you determine what part of the prostate needs treatment?
Yeah, so that's a great question. So I use a couple of parameters. Obviously, I look at the biopsy. Typically, prostate biopsies are done in 12 samples, random samples, typically. Sometimes they're done with MRI fusion guidance. In other words, the MRI, we see a lesion, we did it. So I look at the biopsy report, the pathology report, and I also get an MRI if an MRI has not been done to try and match up to make sure that where I want to treat, that's where the cancer is, and the rest of the prostate is cancer-free. So that's a review of not just a pathology report, but trying to get an MRI to visualize in 3 dimension where the cancer would be.
Gotcha. Thank you. And there's another question about HIFU, and it's actually something I was wondering, this is from the audience, but I was wondering this as well. If you have a local therapy, such as radiotherapy or radical prostatectomy, well, actually not for radical prostatectomy, but if you have a local therapy with radiation, can you salvage with HIFU? And you may have just answered that, I think. But then can you do, this is the flip side of that question, can you do the curative therapies after you do HIFU? So say a man has low risk disease, and they would ordinarily be given active surveillance, and they're not wanting to go into radiation or surgery and do HIFU, those other therapies could follow if necessary down the line.
Yes, in fact, that's those would be salvage therapies after HIFU, so surgery or radiation. You can have HIFU again, you can have cryo, you can have surgery, you can have radiation, and that's probably the least side effect profile of a salvage therapy, because the first one was HIFU, which is very limited in scope and what we treat. If you remember, the target area is 3 millimeters wide, 12 millimeters long. So the effect to other tissue around it is minimal, if any. So salvage therapies can still be done in these patients who fail HIFU.
And then there's a question about TULSA treatment. And I'm not familiar with TULSA treatment. You are. There's a question from a patient who's been diagnosed with intermediate stage 2 prostate cancer and considering focal treatments with TULSA.
Yeah, so TULSA is transurethral laser ablation of the prostate. And it's the newest kid on the block, actually. We use laser to treat many things, and there's a very thin fiber that's placed through the urethra into the prostate live during an MRI. That's how this is done. So the area that you treat with the laser is extremely small. You can't treat a large area like you can with HIFU, and you're limited by access. If the lesion is too far from the urethra, it's harder to get to. But the problem with the TULSA is it's very time consuming, and it's done with live MRI images. And also, we don't have any data on it. It's actually, I'm not familiar with any papers that have been published on TULSA the way HIFU has been around for a couple decades.
And a couple more HIFU questions. One is HIFU FDA approved and reimbursed by Medicare?
So HIFU is FDA approved. However, it is not yet reimbursed by Medicare or insurance companies. We have been successful in getting the patients reimbursed for depending on what their insurance and what their what it states. But I've been told there is going to be a CPT code, which is what's needed to get Medicare to pay for it, and hence other insurance companies to pay for it. I've been told that there will be a CPT code in early 2021, so fairly soon. However, due to COVID, I think that's going to be delayed, just like everything else has been delayed in what the government is trying to do. And just because there's a CPT code, it doesn't guarantee that there'll actually be payment because there's a code. So we're going to go through a period, I think early in 2021 or whenever the CPT code comes into play, where we're not going to know what to do, because we're not going to know if the procedure is going to be paid or not. But I think eventually we'll get there, but it'll take some more time.
And then it was my understanding that the FDA approval for HIFU was for prostate tissue ablation and not necessarily specifically for prostate cancer. Is that right?
That is correct. That is correct. So just like laser or cryotherapy, all these are modalities to ablate tissue of the prostate. And if you have a tool, you can use it, for other purposes. HIFU and cryo have also been used for renal masses, for renal cancer, although there's no FDA approval for that, but it is for tissue ablation. So HIFU is interesting. The history of HIFU is that it was developed here in the United States probably 50 years ago. It sat on a bench. Nobody sort of knew what to do with it. And they tinkered around with it, using it for liver lesions and brain lesions and so forth, until the Europeans and Japanese picked it up and started to use it for prostate. So that was sort of the history of HIFU.
Gotcha. One more question about HIFU. There's a patient who is under active surveillance, and the question is, what point is HIFU normally considered a treatment option?
So we consider HIFU a good treatment option for patients who we think have clinically localized prostate cancer, either low risk, in other words, low grade, or intermediate grade. I've also used it in high grade, but typically when there's high grade cancer, there's usually more of it, and I usually recommend more aggressive treatments such as surgery or radiation. But HIFU can be considered for low volume, high risk disease as well. So for example, Gleason 8 or higher I've done that as well.
But probably for patients who are not considered for active surveillance, those people who would be recommended by their clinicians to go on to treatment, HIFU is probably not a replacement for that full-blown cancer therapy.
Correct. So it has its place, right? It has its place. I think it's a good bridge between active surveillance and more aggressive therapy such as surgery or radiation.
Gotcha. Well, good. There's a number of questions about advanced disease, and there's a question about cycling ADT, which I'm assuming to mean the intermediate androgen deprivation. Yeah, so intermediate.
Yeah. Do you want to answer that, or do you want me to go ahead? So, as you know, Dr. Garrot, intermittent androgen deprivation therapy has been used in the past, and it was shown to be non-inferior to continuous ADT therapy in patients who did not have metastatic disease. That's sort of where it fit. And it was really brought on by patients who wanted to minimize their side effects and come off it, stop it, come off it. But it's indicated for only a specific disease state where the cancer has not spread. Just talking about intermittent ADT for a second, there is some trials ongoing now, or actually the trial's finished, it's in front of the FDA, for an oral therapy, an oral androgen deprivation therapy, where the decrease in testosterone is very rapid, and if you stop it, the uptake of or rebound of testosterone is rapid. So this might be a better way to do intermittent ADT, take an oral rather than a shot like we give now, where the rebound can be rather slow. Or for adjuvant therapy, ADT with radiation, for example, patients have high-risk radiation, we also give ADT therapy. So a pill might be a better way to address that than a shot, which may take them a long time to improve.
I agree, and I recently reviewed that data as well on Localized, and it's actually more effective than Lupron or Localized in getting the T down. So it's more effective, faster onset, faster offset. So you're right, for those settings, it may be the ideal drug for intermittent androgen deprivation, especially if we're giving it during radiation. So that's going to be a market advance that we'll have for that. Let's see, was there one more question? There was one question about mutations, about an AKT E17K mutation. I'm not familiar with that mutation. I don't think that's part of the HRR mutations that you mentioned, but I don't know if you have any experience with that.
I have not. You're correct, Dr. Garrot. It's not one of the ones that we look at in prostate cancer, at least for now. So what's interesting is, we didn't know BRCA1 and 2 were important in prostate cancer. Now we do, we have other mutations. There's probably a lot more that we don't know. We'll probably understand better genetically what's going on with the prostate cancer cell. So, but as of right now, I don't have any information with that mutation for prostate cancer.
Yeah. I do know that AKT is involved with some of the cell signaling with prostate cancer. We at Northside Cancer Institute actually had a clinical trial that was a national clinical trial through Genentech. It finished about a year ago, so we don't have any further enrollment now. But it was with a drug called ipatasertib as an investigational agent that was added to Zytiga, or abiraterone, and it was a PTEN/AKT inhibitor. And there was an ESMO, European Society of Medical Oncology update just recently showed that that drug does have a progression-free survival benefit. So at least some data to say there's a new drug on the horizon. But I don't know about this specific mutation, but the drug we had investigated was the AKT. So it was an AKT inhibitor. So that's kind of neat. I wanted to sort of, number one, say thank you so much for bringing up the PARP inhibitors and the genetic abnormalities, the somatic and the germline mutations that men have, because that has just really revolutionized, I think, the way we're going to approach prostate cancer now. And for starters, all men who have advanced metastatic prostate cancer need to see a genetic specialist, and need to have their germline assessed, meaning, like you mentioned, it's either a buccal swab or a spit test or sometimes a blood test. So very easy to assess the genetics of the whole system. But then if that shows a mutation, that would lead them to be able to receive an active therapy themselves. Many men, in my experience, have not been embracing of genetic specialty counseling or genetic specialty testing because it sort of felt like something peripheral to their own medical care. And it's kind of like, I don't need to do that. Well, now we have a known medicine that targets the mutation that we're looking for and improves survival and improves response rate. And so those men would directly benefit by knowing that data. And whether it's through the tumor or the germline and these, easy to obtain tests, getting that data is so beneficial for them. So, and then what I hope is that, as you mentioned, all those new agents that on your last slide, they will be added to and combined. And that's the typical, strategy with medicines. One medicine shows a benefit, another medicine shows a benefit. You combine them together, perhaps you get enhanced benefit. We may have combinations that are not even going to include chemotherapy any longer. So we are in a new frontier with prostate cancer, with immunotherapy, with targeted therapy, with all these other medicines, the immunobiotherapy with the bioradiopharmaceutical with Xofigo. So we have an arsenal now to treat patients for prostate cancer. I'm 15 years into my career, and even when I started, all we had was hormones and chemo, and that was it. And now we have all this huge numbers of medicines to use. So it's so exciting to be a cancer provider now. So if that's a weird thing to say, but at any rate, let's see if there's any other questions. Maybe one last question about localized disease. The question is, can an MRI be a substitute for a prostate biopsy in regards to monitoring?
So that, oops, am I muted or?
You're on.
I'm on, okay, thank you. So that's a great question. The answer is no, but the MRI is a pretty good test, but it's not a substitute for a biopsy. And there's different philosophies here in North America and across the pond. Across the pond in Europe, they do an MRI on all patients before they do a biopsy. So let's say a patient has a high PSA, the first test they go to is an MRI and then consider doing a biopsy. If the MRI is negative, they just monitor the PSA. That's what they do across the pond. Here, because of reimbursement issues and the cost of an MRI, we typically get the MRI after, although some insurance companies will pay it up front. But it's more controversial, but it doesn't replace. I can tell you a number of instances where a biopsy was positive, even for higher grade cancer, and the MRI was negative, or the MRI shows something, it turns out to be not cancer. So an MRI alone is not diagnostic of cancer, nor is a normal MRI diagnostic of no cancer. It's simply an extra tool, an excellent tool that helps me differentiate who I can need to treat and who I can treat with focal therapy or some other modality.
Excellent. So it's a little after 1. Dr. Kassabian, I'm not sure if you have to go or not. We have one more question if you want to take one more. And this is just in general about testosterone supplementation. This attendee writes, my PSA is 0.6. My testosterone is 582. The doctor at the men's clinic consider it low and would like to raise it to 800. Are there any concerns I should have about getting prostate cancer? I'm assuming this person has not had prostate cancer already, because that would definitely be a no-no. And then the purpose of raising testosterone is to help resolve ED issues.
Yeah, so that's a controversial issue. So let me back up before I answer that question specifically. If a patient has had prostate cancer and they have a low testosterone, giving them testosterone is very controversial. In one way, we may be adding fuel to the fire. Others, though, have suggested that we're not causing any harm. I think this is an informed decision-making between the physician and the patient about what the risk-benefit ratio of somebody getting testosterone, if their testosterone is low and they've had a history of prostate cancer. To answer that question specifically, the PSA is normal. It's less than 1. I think you said it was 0.6. Mm-hmm. The testosterone is normal. Hell, I'd be happy with a testosterone of 500. I don't know how old this gentleman is, but getting the testosterone to 800 to where it was when I was 18 years old, we call that recreational testosterone replacement. We typically don't recommend it because we're not really treating something that's out of the bounds of a normal test. Sure, it's going to make you feel better. You'll probably feel stronger. You'll probably bulk up some muscle. If anybody follows golf, just look at Bryson DeChambeau. I don't know what he's done, but he gained 40 pounds of muscle and can now carry the ball 400 yards. Is he causing harm? Perhaps. Raising one's testosterone increases the risk of cardiovascular disease because it raises erythropoietin levels, which increase hemoglobin hematocrit, which makes the blood very viscous. So you're more prone to heart attacks and strokes. That's the last thing we want to create in a patient.
Yeah, agreed. Very good. Well, okay, maybe we'll wrap it up since we're a little after 1 o'clock, and I think Katie Armsby was going to come back on and give us a wrap up. And Dr. Kassabian, thank you so much for such a great presentation. And we look forward to the next cancer support community educational program for all of our attendees. Please keep in tune for other programs.
Yeah, absolutely. Thank you both for being so generous with your time and expertise. That was a great program. We're getting a lot of thanks in the program chat box. So I do want to, again, encourage if anybody wants to connect with Dr. Kassabian, you can visit the website, advancedurology.com. And with Dr. Garrot, you can visit Georgia Cancer Specialist website, gacancer.com. And I do want to, again, encourage everyone to visit Cancer Support Community Atlanta's website. That's cscatlanta.org, where you can see a complete list of the virtual programs available, which again includes that monthly virtual prostate cancer support group. We're getting a lot of thanks. Thank you everyone for joining us and for sharing such great questions as well. So again, I'm going to wrap up and thank you both. Thank you guys for joining us, and we hope to see you again soon.
Thank you.
Thank you guys.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.